All right, the clock has struck 12:15 and it is the fourth Tuesday of March. We are in spring and we are very pleased to welcome everybody to our monthly clinical conversation session. So I'm Barry Servette and I'm the medical director for MCPAP, and we are really happy to have a really nice presentation for you today. And I'm going to make the introduction of our speaker, but before I do, the reminder is that our clinical conversations always take place on the fourth Tuesday. Our next session is coming up on April 23rd, and the topic is OCD. It's related to OCD, and we'll have a more specific topic that people will get in their email. Today's topic is the Insync Institute, the Insync Instinct, promoting resilience in the context of disrupted caregiving. And our speaker is Dr. Heather Forkey. Just a couple more housekeeping things. As usual, nowadays, we have our CME credit available. And as you see on the welcome screen here, the code for attendance is displayed. It's also in the chat, and the phone number is in the chat too. The session is going to be recorded as usual, and it's always available on the MCPAP website. Tell your friends, people who haven't been able to come. It's just as good to listen asynchronously. The slides will be available on the website too, so you don't have to worry about taking notes. And we will take questions. In fact, we encourage questions throughout the session because it is called a clinical conversation. And so feel free to just enter them in the chat. You can raise your hand if you want to say it out loud, and we'll call on you and unmute you. Most people ask them through the chat, and we'll kind of keep an eye on that through the presentation. And please, if you have a moment, or if you don't, if you can take a moment to fill out the survey at the end, we really would appreciate feedback, not just about how wonderful Dr. Forkey's presentation is, but also about topics that you might be interested in hearing about in the future. So more about Dr. Forkey. Dr. Forkey, we are so pleased to have her. She's been a wonderful friend of MCPAP, collaborator, personal friend of mine as well, and she's a treasure for Massachusetts. She is a professor of pediatrics at UMass Chan Medical School, also the vice chair of the department, and is the director of the FACES program, which is the Foster Children Evaluation Service. She's also the pediatric director for a program called Lifeline for Kids, which is really focused on trauma, and it's a wonderful preventive program. She is she actually received her undergraduate degree from Cornell, her medical degree from SUNY Buffalo. She did her residency and was chief resident at CHOP, Children's Hospital of Philadelphia. She does wonderful clinical work and is also a research scientist, and has been very successful in developing grant projects. She's had local and federal grants focused on helping children in foster care, translation of promising and best practices to address physical and mental health needs of children who have been abused or traumatized. She has published numerous papers and book chapters. She presents nationally and internationally on all of her interests, and she is a leader for the National Child Traumatic Stress Network, and is also a leader of the Massachusetts chapter of the American Academy of Pediatrics, related to her interest in foster care, mental health, and child trauma. And she also co-authored a book called Childhood Trauma and Resilience, a practical guide available from the AAP Press. So we are very delighted to have her. And without any further ado, I will hand off to her for our talk this morning. Thank you, Heather.
Great. Thanks so much, Barry. That was very, very sweet. Thank you. I'm going to try to share my screen with you guys. Here we go. As noted, we're talking about the Insync instinct, how we can promote resilience in the context of disrupted caregiving, and we will define what that is if you haven't heard that term before. I only have to disclose that I have royalties from the book. And we're going to talk about the affiliate response to stress and compare it to other stress responses and ways the brain can change in the human caregiving network. What disrupted caregiving is, some characteristics of that, and some strategies to develop caregiver and child sense of safety, connection, and reward in caregiving to promote recovery from trauma. You know, I think most of the time when I talk, I'm talking about trauma in terms of how it affects the child. And we know, and we talk a lot about how that's related to the stress response, that we have multiple ways to respond to stressors. You can freeze and just stand still, hoping that the threat or the danger goes away. But as humans, we're big and that doesn't work that well for us. You can fight or you can flee, which works sort of in a short term for some dangers, but we're not faster than other animals. We don't have claws. We can't hide underwater. And so, especially if you're a child, that's not so effective. And so we evolved to have a stress response called the affiliate response, which is the one that really is used for most circumstances of stress and trying to negotiate the world. And that means that we actually look to each other and say, hey, can you help me deal with this danger or this problem? And if we find support from other people, we actually have a decrease in our stress response and we attack the problem together. And unfortunately, if I look left and right and the people who are supposed to help me with my problem, especially if I'm a child, if those people can't help me or are a cause of the danger or the threat themselves, well, now I've got two problems. I've got my original issue and I've got this new danger in you. And so what happens is without affiliate support, we all, but in particular kids, get shoved over to overusing fight or flight responses, and that has consequences because in the short term they allow the child to survive and manage, but we know that overuse of cortisol, that overuse of the sympathetic nervous system has consequences on the brain and development and mental health. Not as relevant to this conversation, it also is impacting the immune system and the gastrointestinal system and the cardiovascular system, leading to consequences throughout the lifespan. And in fact, in pediatrics and in psychiatry, we really have to be thinking about this all the time because early or significant relational trauma, that inability to use the affiliate response, really leads to many of the diagnoses that we're managing kind of all day, every day in our practices. So it really brings us to the question of how do we avoid having kids who can't use the affiliate response? And what is it that we're trying to promote? I mean, we say in parenting, don't just say no, tell the child what you want to see. So what do we want to see? If we don't want to see kids shoved to fight or flight, what we do want to see is use of this affiliate response. And so what we're trying to do in medicine is not really just sum the suffering, counting up the adverse experiences and giving people a number, but really our job is about building that buffering, is about creating opportunity for children to be able to use the affiliate response effectively so that they can shut down their stress, manage the world. And what we're trying to promote there is resilience. And resilience is kind of gotten a little bit of a bad name because people sort of say it's blaming people if they don't survive the trauma. But I would suggest that Ann Maston's definition is really what I'm talking about. It's this dynamic process of positive adaptation to or in spite of significant adversities. And we can use resilience in all sorts of circumstances, but for kids, the pathways to resilience are rooted in the give and take of safe, stable, and nurturing relationships that are continuous over time, or the attachments that kids have. And it's not extraordinary, and it's not something you're born with. Kids grow in resilience through play, exploration, and exposure to normal activities in the context of those safe, stable, and nurturing relationships. And in fact, further defining what it is we're trying to promote in kids, we can look again to Ann Maston because she took this resilience definition and she said, and what is happening in that process is that kids are developing a number of things. And I have an unhealthy relationship with mnemonics, so I took her list and I sort of turned it into a little bit of a mnemonic because I think that these are the things that we want to weave together for kids so that they can kind of come out with the most resilience possible. And in those safe, stable, and nurturing relationships, in those activities, they're developing their thinking and learning brain. They're developing a sense of hope for the future, that there is a future for them. Most fundamentally, they're developing a sense of regulation or self-control. They can manage themselves so that they can learn to manage anything that comes their way. And to that point, they have efficacy, meaning they feel like they have a sense of control or management and that they can affect change and be successful. That requires there to be this attachment with that caregiver, that safe, stable, and nurturing caregiver who's reliably present. And what that caregiver does is allow them the opportunity to develop skills, and it also creates a safe place from which they can make further social connections and more of those safe, stable, and nurturing relationships in their world. And so really what it kind of comes down to is, if we keep sort of peeling the onion, we are thinking from our perspective in medicine, particularly in pediatrics and psychiatry, how do we promote these safe, stable, and nurturing relationships? What is at the root of them? And this is a really interesting aspect of science that I just never learned in my residency or in my training. And it's so important for us to know because, you know, human babies are born with a huge amount of development to go, right? So the human is born and they're not really ready to face the world. I had a professor who used to say, you know, as a human baby is born at 9 months because the head has to get through the female pelvis, and 9 months is the maximum amount of time. But the human baby is completely undercooked and not ready to be born. And that's true, right? Like we look at the Nature Channel and the giraffe is born and falls from the mom, snapping the umbilical cord, and in moments later, they get up on their wobbly legs, they walk over to mom, they and mom decide where they're going to go eat, and they go eat solid food from the leaves of the trees. You know, humans have this massive amount of brain development that has to happen. And in order for a child to develop in a safe way, we had to evolve so that the parent brain would sort of take over as that child brain had the opportunity to develop to a place where they were safe. And so the child has this constant process of meaning making that is directly in the scope of that caregiver, right? That the child comes to understand themselves and the world in the interactions with the caregiver. The child is, their world is reflected by the caregiver, and the child themselves is reflected by the caregiver. They come to understand themselves that way. And that requires some steps to it. So the first step is that the caregiver has to attune to or figure out what the child's emotional state and be in it with them. And the child feeling that they are understood in that moment. That caregiver saying, oh, baby, you're hungry. Let me be in it with you and name it for you and help you to see that this is the feeling that you have. And as they attune, most critically, the caregiver is syncing with that child, not just in terms of how they're thinking, but also in biologically other ways. Their heart rates are matching. Their cortisol production is matching. And in fact, it's not unique to infancy that this happens. It happens that we get in sync with other humans throughout our lives. And it's in those interactions that we learn, that we grow, and that we often feel like we're having our most important and affirming interactions. But this syncing is the mechanism by which the parent's mature brain externally regulates that infant's immature brain, tuning it in to this social life that we as humans have developed. You know, this idea of synchrony is so critical, and the studies that have been done have definitely used sort of traditional gendered roles of mother and father. But what they have found is that when a mother is in sync with her child, holding the baby, their heart rates match within milliseconds of each other. Their cortisol levels match. And if a child has developed this sense of synchrony with a mother figure, and it doesn't, as I said, have to be just a mom, but that's how the studies were done, they become aware of their internal selves, right? The mother is paying attention to, oh, baby, you're hungry. Oh, honey, you're frustrated. And what we know is that if we look at kids as they grow, kids who've had that synchrony with a mother figure as they grow, they have a better sense of their own and other children's emotions in kindergarten. And in adolescence, they're much less likely to have both externalizing or internalizing problems of depression or aggression. In contrast, in the studies done, the synchrony that kids have with father type figures is much more brief, it's much more externally focused, and it's attuned to the external world. They often have these moments of kind of direct syncing in together in a very excited way. And kids who have those opportunities, we know that in early childhood are much better at negotiating their way with other young children. And in adolescence, they can be engaged in conflict with other kids, but perceive the other child's point of view in a much better way. And so really this critical piece of biobehavioral synchrony allows kids to begin that process of regulation. We start by co-regulating. The caregiver regulates themselves, managing their own emotions, so that they can co-regulate with the child and teach the child this is how we manage it. So the mother attunes, oh baby, you're hungry. And she's syncing behaviorally with that child. And the child is learning, oh, I can manage myself in this event. And they are fed and the child learns, oh, I can communicate my needs. I am worth having my needs met. I am able to manage and get what I need, and there's solutions to the world's problems, and I am worthy of having that attention. When the child's a toddler and they get frustrated, a caregiver regulates themselves. They don't freak out and they say, hey buddy, it looks like you are frustrated. They name it and they say, let's see if we can figure out how to solve this problem. And in toddlerhood, they might take the child's hand. In early childhood, they might say, let's use your words, or let's think about what else you know. In adolescence, that dyadic co-regulation can look like saying, hey, let's walk through how you talk to that teacher and how we might try it and practice that conversation that you might have tomorrow. And the child then is developing those self-regulation skills that they can take over and go forward with. The interesting thing is that we used to think about that caregiver's ability for that attunement, synchrony, and co-regulation as being somehow automatic. The babies were so cute that a parent would automatically do that. What we really understand now is that there are profound changes in the brains of people who begin to parent that allow them to do that work, because it is not always easy. In fact, the brain of people who are beginning to parent has changes in a number of areas. In particular, the orbital frontal cortex changes so that people begin to orient to infant cues in a way they didn't before. You know, if my oldest daughter recently had a baby, and if I go to the grocery store with myself, my daughter who just had a baby, and one of her adolescent brothers, and a child cries in the store, my daughter will be able to hear nothing but that baby crying. Where's that baby? Who's helping that baby? I can hear the baby. I recognize that it's happened. My adolescent son has no idea that anything's happened. What? I don't hear anything. He doesn't have that orienting yet because it's a change to my daughter's brain. There's also changes at the reward pathways, because you know what? Parenting isn't always very rewarding. So we have to have a change in our reward pathways so that staying up all night with a crying baby and they finally smile is enormously rewarding to a parent. There's also gray matter changes in motivation centers, making it so that parents are much more likely to be empathetic. In particular, males are not as empathetic before they parent as after. And with mentalizing, that ability to look at the world from the child's perspective, that all those parts of the brain are all changing. In particular, the dopamine and oxytocin reward pathways are stimulated, particularly in the nucleus accumbens, which is the reward center, and the ventral tegmental area, which produces dopamine. Those are massively changing. So again, that parenting can become rewarding. And, you know, initially we thought that this was just happening in the brains of people who give birth to children. But it turns out that it's happening in paternal brains too, that there's significant neuroplasticity for all humans. And it becomes shaped not just by the hormones of pregnancy and breastfeeding, but it's changed by caregiving experiences, maternal and infant stimuli, as well as the ecological conditions. And so this is really a global parental network of change to the brain of parents, making it possible for them to do that attunement, biobehavioral synchrony, and co-regulation. Ultimately, again, I have an unhealthy relationship with mnemonics. I created this mnemonic because there are different systems and different parts of the brain that have to change, but it creates 5 ways that the human brain changes to allow parenting to happen. The first is that you have to have this sense of safety. You cannot be fearful being close to the child. You cannot be operating if you're constantly feeling under threat. You also have to have this pleasure from interacting with the child, this implicit reward in parenting. You have to have this belief that you can do this job, that I'm a good enough parent and I can do this. You have to have enough executive function to stay the adult in the room. And even when things are kind of going sideways, that you're not going to act on those base impulses. And finally, the R of these fibers is that reflective functioning, that ability to attune to kids' inner lives and reflect how they feel to that child. And for those of you who are geeky like me, there are particular regions of the brain that are responsible for each one of the fibers that are being changed so that this parenting can happen. What's really interesting, though, is what happens when a caregiver has experienced traumas or depression, in particular postpartum depression or substance misuse. And what we know is that all of those challenges, such as trauma, depression, and substance misuse, are going to impact the brain at the same place that the brain needs to change so that it can parent. And so this has been named disrupted caregiving, when that child caregiver relationship is impacted by those challenges because the specific brain structures that need to change for parenting have already been altered in other profound ways by trauma, depression, and substance misuse. So let me give you a little bit more detail. We know from many of the lectures you've already heard, the trauma in particular impacts the cingulate cortex, the amygdala, and the parts of the brain like the prefrontal cortex and the emotion regulation centers of the anterior cingulate cortex that are responsible for the attunement to a child, the attention to a child, the mentalizing required for a child, and that sense of empathy. But for a parent who's experienced the trauma, those changes are going to be much harder to happen in the brain. Interestingly, postpartum depression causes changes to the same areas of the brain required for parenting in this human caregiving network. And I always used to wonder, like, why does everybody want us in pediatrics to screen for postpartum depression only? Like, why are we not screening for other mental health issues for parents? And one of the reasons is because postpartum depression is so common. But the other piece is that these disorders have unique neural profiles during the postpartum period that are different from depression at other times in life, and uniquely overlap with the systems required for maternal caregiving behaviors. And so mother-infant interactions are most susceptible to disruption from postpartum depression. Finally, substance misuse. There's some significant changes to the gray matter when someone is substance misusing. In particular, the orbital frontal cortex doesn't develop the way it needs to so that parents can parent and orient the child, and those reward pathways are disrupted. Interestingly, the reward pathways that are most impacted are impacted by substances that not everybody is even thinking about when they're thinking about substance misuse, right? So the nucleus accumbens is impacted by cocaine, amphetamines, and opiates, but it's also impacted profoundly by THC. And the ventral tegmental area is impacted by ethanol, nicotine, THC, again, things that we're not always thinking of as substance misuse in the same way as we think about opiate disorders. And so many times parents are turning to these substances to manage the stress of parenting and undermining the very ability to get joy and reward out of parenting when that becomes a problem. And what we see in disrupted caregiving is a different type of parent, right? So we talked about the parent when the baby is hungry and they say, oh, you're hungry, and they feed the baby, and the baby comes to understand themselves and the world. But for the disrupted caregiving situation, when a caregiver is dealing with their own substance misuse or mental health challenge, and they say to the baby, why are you so greedy? Would you just be quiet? Or when the child is frustrated and the caregiver, instead of saying, hey, buddy, you're frustrated, let's help with that, they're saying, what are you, stupid? You can't figure it out. What you're seeing there is some frightened or frightening behavior, a lack of joy, this impulsivity, this jumping in instead of sort of taking a step back, this lack of sensitive, responsive care, and very negative reactions and negative perceptions of even neutral stimuli from the child. In fact, what's happening is that these caregivers have decreased perception of those child cues. It's not that they're choosing not to respond. It is that they do not perceive the same cues from the child. And they have decreased motivation to interact or breastfeed or engage. And because of prefrontal cortex impacts, even if they do engage, they find parenting overwhelming because their problem-solving skills are impacted by these other challenges. And so we see this intrusive, angry parent who is impulsive and doesn't see parenting as rewarding. They need to soothe their own anxiety, and that's overriding parenting. And their cognitive resource, their ability to sort of manage the day, is overwhelmed by craving or anxiety, and so they've got no room left psychically for parenting. Now that's critical for a child because that attunement and synchrony is critical for the child. And when the internal states are ignored or misidentified because of the parent distress, the parent can't support the child, and the child then misidentifies emotions and their sense of self. That baby who is told, what are you so greedy, begins to associate hunger with being greedy and something bad. And they don't have a sense that they are worth being taken care of. And they don't have a sense that the world is manageable or that they're able to communicate what they need. And the caregiver who's told that they're stupid when in fact they're frustrated misidentifies frustration as stupidity and will carry that forward into academic settings and be much more likely to give up or to identify themselves in a way that is misidentified because their sense of self and their sense of how to negotiate the world has been altered by this mismatch. So many of you are saying, well, why did I give up my lunchtime for this happy talk? It seems pretty hopeless to me. And yet, it's not hopeless. And I'm here to say that there's good news in this. And Ed Tronick has done a lot of this research looking at the fact that we used to think that caregivers and parents had to be connected and in sync all the time. But of course, that doesn't make sense. It doesn't work with the world, right? Like even in the healthiest relationships, the doorbell rings, the phone goes off, meals have to be made, other kids have to be attended to. A parent cannot constantly be in sync with the other child. So in fact, what happens is that caregivers and children have matching of meanings and understanding, and then there's a disruption and there's a mismatch. But then they come back together again in this reparation. And it is actually in the reparation that kids find the most meaning about themselves and about the world. And so for those of us who work with kids and families, this opportunity for reparation becomes our opportunity to interact with parents who are struggling. So what we want to do is think about, of the fibers, which ones do we want to start with, right? Like I can't, in the 15 minutes I have with kids and families, probably address everything. But if I think about what has to come first, second, and third, I'm going to start with that helping a caregiver to feel safe and a sense of joy, because only when they have those two as the base can they get to thinking about the child's perspective and executive functioning, and then a sense of their own meaning making as a capable caregiver. And so we really want to start by addressing fear and that reward in parenting. You know, that fear is so critical because for a caregiver to be able to reflect accurately to a child, it's like water reflecting, right? Water has to be calm to reflect accurately. And safety helps to calm the caregiver so they can be much more accurate in what they reflect to the child. And so we want to start by helping a caregiver to have a sense of safety and calm. You may say, well, I have a lot of things to do, Forkey, I can't. But of course, we can reflect as we do other work. We can be narrating and we can be interacting in a safe way with caregivers as we continue to do other work. And this can just sort of be the how we do it. And it's becoming the what we're doing as well. It is worth pausing here, though, to remember that what we reflect to a caregiver can sometimes depend on our lens and our focus, and culture and context really need to be considered, because as I reflect to a caregiver, it can change how the caregiver sees themselves. That's how this works. But particularly with caregivers who are struggling, we can sort of feel some of the animosity or frustration with what they're doing. Those negative behaviors, that sense of impulsivity that we see them acting on, can cause in us reactions that are not going to be healthy for us to reflect. And so we need to sort of say, you know what, it's okay for us to have those reactions, but we want to play them out, not with the parent, but with others that we work with, right? Because, you know, I mean, we can have these interactions with caregivers, and you can leave those interactions and say you wouldn't believe what that mother just did and said, and kind of be looking for support, affiliate support from the others that you work with. And I would challenge you to sort of ask those of you that you work with to sort of say, yes, but let's think about what this caregiver is going through. Let's look at it with that other lens and focus. Yes, that was harsh. Give the affiliate support, but also challenge each other to begin to take this new lens. So let's talk about some techniques and strategies and resources to strengthen those fibers. Because primarily what we want to do is we want to help a caregiver to identify some sense of safety. You know, like if I talk to a caregiver who is overwhelmed by their own postpartum depression or substance misuse challenges, they will often, if I say, you know, what do you find difficult? The answer will often be everything. Everything's difficult. Everything's hard. There's nothing that's not difficult. And so what you can do is you can create a safe place in the interactions you have with that caregiver, interactions that reduce instead of increasing their sense of shame. And Claudia Gold talks about starting with this stance of not knowing, coming into the situation and asking the caregiver what the child's behavior or the situation means to the caregiver. Allowing yourself the opportunity to look at it from the perspective of the caregiver and validate that that might be how they see it. Don't invalidate, like that's not the right way to look at it, but say, I can understand why you might see it that way. That makes sense to me. Because that relationship is really your patient or your client. And caregivers are coming with the circumstance that just happened, but they're also coming with their own histories of having been parented. Those ghosts or angels in the nursery, as some of the literature has taught us. You know, we often talk to parents who have, you know, we work with birth parents when children have been removed, and they often don't understand why child welfare is saying that they neglected their child, because they are parenting just the way they were parented. And for them, there's a normalcy about that. And we want to be able to allow them the opportunity to voice what it is that they experienced. And again, to validate who were the people that they turned to and what were the complicated relationships there, allowing them to recognize that they may be bringing forward into this new relationship with their child some of either what was good, the angels, but also some of what they don't want to repeat for this child, those ghosts. The other thing we can do is we can help caregivers to begin to think about who is in their life that they may not be recognizing, because caregivers will say, I don't have anybody to help me. And indeed, that's exactly how they feel. So we can do this support mapping where we say, okay, I hear you, that you feel like there's no one that you can turn to help you. But what if there was a fire or an earthquake or a flood in the middle of the night? Is there a downstairs neighbor? Is there a next door neighbor? Is there your mother live nearby that you would call in the middle of the night? And usually people will be able to identify someone who has proximity that they have at least a minimal relationship with that they could call. And that begins sort of that process of recognizing that there are people. And so then you say, okay, well, what about the next day? Who would you call? Well, I'd have to call the school, right? So we have people at the school. There's the teacher, is the principal someone that you could talk to as well? Would you talk to another relative who lives at further distance? Would you talk to your physician? And bring in sort of that next level of people. You want to talk about who might be specific to helping you understand this child. Is there an old daycare provider that you still keep in touch with? Or is there somebody who particularly likes this child on your block? You also want to mention who to avoid, because sometimes stressed parents will turn to other kids in the household, like the older sibling, and lean on them in a way that's not really healthy for that child. Or they may turn to relationships that are not healthy for them, like an ex-partner or a parent who wasn't a good role model for them. And so we want to identify who to avoid. The other thing we can talk about is how to promote that sense of synchrony, right? We think about synchrony in terms of infants, how you gaze and rock and sing and overdo expressions, you know, ah, ooh, ga, and those exaggerated body movements, which of course you're not going to do with an older child. But there are other ways that we can promote synchrony by marching or dancing or storytelling, chanting, praying together, singing together are all ways to come in sync. We talk about how crew teams are often very, very close because they do this syncing constantly, this biobehavioral synchrony in their rowing. But you can run with someone, you can jump rope with your child. And again, it's bringing back that syncing. Even having a discussion of what you have in common or family traditions or joint interests can bring people in sync. But one of the number one ways that we have to promote synchrony is by promoting play. You know, when I was first looking at this literature and I came across this, I was like, well, this is kind of silly. Like, who needs to learn play? And it turns out that many people who have not lived in a safe setting, never learned to play as a child, and are not in a situation where they have felt safe enough to play. You know, play increases safety, a sense of safety, but you have to have a degree of safety to even play. You know, the way you could think about it is, how would you play if your child was running out into traffic? Well, of course, you wouldn't play in that moment. You'd just be dealing with the threat. So recognizing that many of our families feel like they're dealing with threats all the time, you want to think about moments that you can create where we can shut down that sense of threat and operate in this opportunity to build skills in play. And as we talk about play, you may have to prescribe special time in, which is where the parent picks the time, what time works for them. And it can't be when they're trying to make dinner or do something else. But then the child gets to pick the activity, and we set a timer for a very short period of time, like 5 minutes, but the child leads the activity and the caregiver is entirely focused on that child and that activity. And then you want to check in with that parent, because what we'll find is that the child loves that time. They're getting what they need, but their behavior sort of dysregulates more once it's over. And it's really the child sort of beginning to recognize what it is they need and kind of screaming for it. So you need to connect again with the parent and think about other opportunities to bring that special time into a bigger period of time and other times in the other interactions that they have. We also may need to guide what play looks like, because not all parents know how to play and not all play is the same. I had a parent who was getting custody of his son back, and I asked him, so do you play with your child who was 3? And he said, yeah, we play all the time. And I said, oh, what do you guys like to do together? And he said, I put him on the ATV and we ride around, which is not exactly what I meant, because I'm a pediatrician, so putting a 3-year-old on an ATV makes me very anxious. But what I also meant was that it's play that's face to face, where you're talking and smiling with each other. So we're talking about blocks and Legos and toy animals and drawing and painting, things where you're really interacting. And again, with this dad, as with some of your parents, you might need to be careful about what you're trying to promote as they play, where you're saying you want to do the P's, praise and paraphrase and point out, wow, look at that dog you're drawing. I think that's our dog. It looks a lot like our dog. Praising, paraphrasing what they're doing, pointing out what you see. And to avoid the cues, because oftentimes caregivers who have been in this negative headset have this sense of impulsivity and frustration, want to lead, they ask a lot of questions, and they do a lot of don't do it that way. Well, that doesn't even look like the dogs. Why would you make a dog a purple? The dogs are never purple. So you want to make sure that you're saying, you know, like, let's avoid all of those cues. There's some great references that kind of come up with examples, because sometimes parents who are stressed this way can't even imagine what they will do with their child. And of course, there are many things that you can do that require a short period of time and not extra supplies. Even things like emptying the dishwasher in a funny way or watching a cat video together can be opportunities for caregivers to have these moments where they're syncing and allowing that child to get a sense of play and joy from the caregiver relationship. What's happening as they sync is that there's some co-regulation happening. The caregivers are beginning to label feelings. I can see you're pretty excited about that tower that you're building. We can have them begin to breathe together. We can talk about ways that they can calm their bodies together, sort of taking a breath and relaxing from their toes to their head. There's a fun way to do this called backstories, where the child draws pictures of as they tell a story on the caregiver's back, and the caregiver has to guess what it is the child is drawing, and then the parent has the opportunity to do that for the child. Sharing music or sensory activities, other ways where parents and children together, the caregiver is co-regulating that child. You know, regulation requires some relaxation, that connection, and that ability to express feelings. And so as we talk about this co-regulation, what you can do is you can also talk to caregivers about apps that they can use to help, especially with that relaxation and with the ability to name feelings, but they're doing it connecting with each other. And so as you bring in these apps and these opportunities for them to do it at home, you're creating the whole experience for the parent. One other quick way I will sometimes do is if there's a lot of animosity with a child and an older child and a parent, is we'll talk about an event that happened and we'll talk about, well, let's just play a game. Let's just play a game where you are each other. And I want you to play out that scene, but do it from the headset of each other. So mom, I want you to be the child, and child, I want you to be mom. And I want you to kind of go through this conflict that you had about when you came in from being out with your friends, and let's go. And it has to be used sort of in the situation where people are calm enough to do this, but it allows them that opportunity to kind of begin to attune, to have that biobehavioral synchrony, and to co-regulate each other as they create this meaning and begin to understand each other from the inside out. And so in summary, what have we talked about today? We've talked about the fact that the affiliate response is the way kids manage stress in the healthiest way, and that attunement, biobehavioral synchrony, and co-regulation are the pieces underlying the benefits of safe, stable, and nurturing relationships, those people with whom you are going to be able to affiliate. Traumas, stress, depression, substance misuse result in impacts on brain systems needed for caregiving, particularly the sense of safety, reward pathways, and executive function, which impacts that ability of the caregiver to attune, provide that synchrony for the child, and to co-regulate. We have to be careful about our own parallel processes impacting our ability to provide care for parents who are dealing with these challenges. Addressing it with our coworkers can really help with that. We want to come to patient visits with this stance of not knowing, without shame, and opening it up for the caregiver to express how they are perceiving the situation, validating that, and then working to sort of frame shift. And we can do that shift by promoting play, relaxation skills, and even role play to support that intrinsic reward or joy of parenting and reflective functioning. Really interesting resources that you might want to reach out to, because this whole literature was new to me when I first came across it just a few years ago. So let me stop sharing here.
All right. Thank you so much, Dr. Forkey. Do you want to, so you're stopping for questions? I'm monitoring the chat, and we do not yet have any questions, but I would like to encourage anyone who has curiosity about this to feel free to ask questions. I love the idea of not knowing. It's hard for us doctors, I think, to adopt that stance, or it's just that sort of mindset, but it's a very clinically valuable way of just interacting with people too, without sort of, assuming or acting as if, we know things that we really don't. We certainly know a lot, but we don't know, sort of what people are really experiencing. And so, yeah, I don't know if you have anything more to say about that.
Yeah, I mean, I think it's been, the other ways, Brene Brown calls this the most generous interpretation of events, or, there's other ways that people have expressed this, but that opportunity to try to really come into the circumstance and come to understand it. We talk about looking at the world with the other person's mind in mind, sort of trying to create the opportunity for you to get inside their head. There's another concept called epistemic trust. And what that means is that we're not willing to learn anything from someone unless we believe that they look at the world from our perspective. And in the United States today, I think this is one of our biggest challenges, right? Nobody believes that the other side is looking at the world from their perspective, right? And so they are unwilling to hear anything they have to say, even if there might be some good ideas on either side. We can't hear it because we do not have this sense of epistemic trust, or belief that others are looking at the world with our perspective in mind. In particular, I think we have a challenge with this in medicine because we have been quick to say, just trust us, we know what we're doing, this is absolutely the right way to do it, when we actually may not have been sure about that. And so people have come to mistrust, and coming to medical settings, many people come with a sense of mistrust. And until they believe that we, as their medical provider, are willing to at least look at the world from their perspective, they can't hear what we have to say. They can't learn from us because they do not trust. And so I think that that's also comes in this stance of not knowing, this opportunity to sort of say, I really want to understand what it is that you're living so that I can kind of look at this problem from your perspective, not mine.
Yeah, I think that sort of it sets up the stage for truly sort of family-driven, care as well. Like when you, are able to kind of create this relationship, and really kind of, hold that kind of space, with people, within a relationship, then, you get to find out, what people really care about, what really matters, to them, how they understand it. And that's, such an important thing for us to know if we want to be, family driven, in our work. I hope we do. I'm not sure not everyone does, but I hope we do. And it's so important for trauma-informed work to really put the patient, really at the center, of this. But it goes back to like being like everything's relationships. Like MCPAP is relationships. Yeah. Your work with patients, it's the foundation of that work is relationships. And when you have a relationship, when you've cultivated it, as a primary care provider or as specialist, then you have that shared perspective. That people know that you understand their perspective if you have cultivated a relationship, that's based on not knowing and based on really caring, about what the other person, really thinks and how they, make meaning out of what's happened, to them as well. Chat still empty. No questions. Anybody? Oh, look at that. We just got two. So the first one is from Ifuru McLeod, and it's, can you explain a little bit more on what the child behavior means to the caregiver? Do you understand that one?
Yeah, so oftentimes, especially caregivers who are struggling, feel like the child's behavior is intentional and directed at them. An example, or they're interpreting the child's behavior through the lens of their own prior experience. So, one example of this that I often kind of go to and think about is I, for many years, ran the child abuse team here at UMass and was sitting with a mom whose 9-month-old had been brought in with abusive injury. And the child had been in the care of her boyfriend while that had happened. And we were sitting talking about what this mom understood about the situation and whether she had had concerns. And she said, well, my baby is just aggressive like his dad. And I said, oh, tell me more about that. And the baby was in the crib as we were sitting in the hospital room together. And the baby was in the crib kind of doing the 9-month-old thing where they were trying to kind of get up on all fours and pushing around and making a lot of, energetically moving around the crib. And you said, and what the mom said is, you see how aggressive and angry he's hitting the bed. He will hit anything. And so the mom was really interpreting normal baby behavior from the lens of sort of this experience of having experienced the violence with her partner. And as we found out later from her early life, from caregivers that had been violent toward her as well. So she's now interpreting the child's behavior through that lens. And that's the kind of thing that we're talking about, is that parents sometimes come to what we can't even imagine is how they're perceiving the situation or the behavior of a child. You'll often find that parents say that toddlers are doing things on purpose to spite them. We often see this with toileting accidents, that they're doing it on purpose. They could definitely manage it. So they don't sometimes understand child development, or they've got their own lens to what's been going on. And so you can't begin to intervene effectively if you don't know what that lens is, if you haven't understood from their perspective what it is. And so that's where that opportunity to sort of say, tell me how you understand this behavior. What do you think the child, every behavior is a communication. So tell me what you think is how have you interpreted this? Oftentimes parents also have some very accurate ways to understand their child, that they'll tell me something about what happened to a child and they'll say, well, he's really responding to the fact that X, Y, or Z happened. And, we even get some more of the story. So I think those are all kind of what I'm talking about.
Yeah, that's great. I think those are great examples, and I think the person who asked the question agrees, with that. And I think that a lot of times our first reflex is to rush to judgment, about these kinds of, attributions, that the assignment of meaning, by a parent to the child's behavior, is based on their life experience, their lived experience. And sometimes we see it as irrational, as doctors, and we might sort of feel like we need to correct them, and we do need to correct them, but the way that we correct them has to be in a very kind of empathetic, sort of way, because the reason why they have these attributions and why they make the meanings in this way is based on their life experience, and so it's a delicate matter, but I think we all have to, be very patient, with people around those things. There's another question that says, do you have thoughts on how to support caregivers when we anticipate a disruption is coming for a child? For example, changes in foster placement or removal, I'm sure from parental rights or termination of parental rights, things like that.
Yeah, I think what we come back to for kids is recognizing that sense of safety is so paramount. And so for caregivers to be able to promote, how is this child going to feel a sense of safety or affiliate support if they know that the child's going to be reunified, reassuring the child that they are always safe with this foster parent, but they're also going to be safe with mom and dad, and that we wouldn't let anything happen to them. Talking about the routines as a way to shut down the stress response and promote, if a routine has to change, prepare the child for that change, but also try to continue routines when changes have to happen. And then also giving the child some skills around regulating, talking to the child about, how can you, when you have these feelings of being upset or frightened, let's talk about ways that you can manage it and how you're going to do that. So I think we think about that as the 3 R's. So it's reassuring safety, returning to routine, and promoting regulation as the top 3 things for kids, especially around transitions, or because safety. I mean, I started this talk talking about stress response, and we want always for these kids to be able to use the affiliate response and not go into fight or flight.
Very nice. All right. So we do not have any more questions. We'll give people another moment to enter them. And but it does not look like that's happening. So I think we'll end. Thank you so much again, Dr. Forkey. This was a really, really fascinating topic and a really great presentation. And
Barry,
thanks again for presenting. Dr. Strauss.
I just wonder if we have a couple minutes, we could explain our new early childhood program so that people know that that's available.
Ooh, that is a good idea. Shall I do that, John?
Sure.
Okay. So we actually are fortunate enough to have some additional funding from HRSA, with the Pediatric Mental Health Access initiative, or it's a big federal program that's really helped to expand and spread MCPAP-like programs around the country. And so we got a grant to expand our program to include an early childhood arm to it. And so we have a special team of people that's led by Dr. Yael DeVere at the central hub of MCPAP. And that team is preparing all the teams really to be able to receive calls about young children to help evaluate the presenting concerns, to help to kind of support the primary care team in terms of developing appropriate treatment plans. A lot of this work is going to be done by people who are not medication providers, and part of that is, because most of these kids do not need, medication. We're talking about kids 0 to 6, sometimes 0 to 3. And a lot of the work really has to do with assessing the attachment, issues and the parental dyad, and assessing sort of the different kinds of social determinants of health and, issues that impact the relationship, between the baby and the caregiver, but really it can go into anything, and it's diagnostic. It's helping to sort out what these kids need, and also helping to provide their evaluations. We're going to have the capacity to actually help to do autism assessments remotely with our own staff, to try to make sure that kids are getting the assessments they need to be eligible, for early intervention and other kinds of services that they might need. But it's really a whole new branch of MCPAP, that's really meant to address early childhood mental health issues, which are often related to the topic that we're talking about today in terms of trauma and attachment issues. Yeah. John, would you add anything to that?
Oh, that sounds great.
It is great. Yeah, we're excited.
And you reach the service just like you always do by calling your regular MCPAP number, and you may be offered to have a call back from someone on the early assessment team, and we hope you'll take us up on that, and it may mean that you won't get a call back quite as quick, but we think you'll get better service that way.
Yeah, we're looking forward to hearing from all of you about these kiddos and their families. So I think we will adjourn, and just as a reminder, the next clinical conversation is April 23rd on the topic of OCD, and just keep an eye out for more information about the title and the specific focus. And thanks again so much to Dr. Forkey, and I hope everyone has a really nice day.
You too. Take care.